In this video, we're going to continue with Chapter 7 on patient assessment, and we're going to focus on the secondary assessment, especially the physical exam part of that secondary assessment. Remember, these 5 steps were right here as we describe everything in this video. You'll hear a couple of terms in this video, in particular, palpate, being able to put hands on a patient and look for anything in that mnemonic decap bottles, which we'll talk about in just a bit. Remember, secondary patient assessment is where we are. We've already made the scene safe and done our scene size up. We've already addressed life threats in the primary assessment and collected a patient history. So, considering those 5 parts, as always, we want to make sure that we're systematic and standardized. For most of us, that systematic and standardized approach allows us to be pretty thorough in terms of this physical assessment of the patient. And that's really going to allow us to ensure that any traumatic problem that may have been overlooked during primary assessment is uncovered during this hands-on physical assessment. So being systematic for most of us means we're going to work head to toe. As we put hands on, we always have to make sure that we have permission or consent from the patient, and if the patient refuses, do not proceed. We would be guilty in that case of battery. We always want to touch the patient wearing gloves. That's for our own protection. That's our universal precautions, but also it provides a setting in which it's a little bit more professional, a little bit more clinical. You may cut clothing to expose an injury if necessary, typically when dealing with a critical patient. We're after identifying specific clinical findings that help us understand what's going on with the patient's current problem or injury. Don't be afraid to put hands on and palpate the patient. Touching is just this essential part of the exam process, and we need to do so firmly so that we can uncover these things. DCAP BTLS stands for deformities, contusions, abrasions or avulsions, punctures or penetrations, burns, bleeding or bruises, tenderness, which is different than pain, lacerations, and swelling. Now we're going to begin by just taking a look at the skin. The exposed skin and looking for color, temperature, and moisture gives us an idea of perfusion. If that patient is pale, if their skin feels cool, if they appear a little clammy with some diaphoresis or sweating, that patient may be a little bit more critical than the patient whose skin looks very perfused and it's warm and it's dry. We always have to account for things like weather when we're assessing this, but it's a great place to start. Then, for head to toe, let's just start at the top of the head. We're going to look at and we're going to palpate their head, their scalp, and their face. We're going to work from back to front, posterior to anterior. And as part of that, we're going to just take a peek at those openings in the skull, the ears and the nose in particular, looking for what might be cerebrospinal fluid or looking for bruising behind the ears that's indicative of a skull fracture. It's called battle sign, although it shows up pretty late. When we examine the eyes, we have a separate skill guide describing this, but using our pen light, we can look for the reactivity of the pupils, and they should be equal, they should be round, and they should be reactive to light. If we see, for example, as shown here, pupils that are unequal, it could be normal for the patient. We'll need to follow up and we'll need to ask. For eye movement, remember, we're going to ask them to keep their head still, give them a focal point, and track with us. That's looking at extraocular movement, and that's specifically tied to some of the cranial nerves that we have inside our brain. And if eyes are moving correctly, we can note that that extraocular movement is intact. Continuing head to toe, then we can take a look at the face. We're going to look for symmetry. If we see drooping on one side, we know that may be indicative of a patient, for example, with a stroke. We want to again look more specifically at the skin color there, and we may need to assess the stability of the facial bones by applying pressure to those bones. Oftentimes, it's enough if we can just ask them to kind of clench their teeth, and if they're unable to do so or if that's painful, that's indicative of some sort of instability. Checking for broken or loose teeth or some cuts, swelling, or bleeding is important for us because then we can be confident that they can maintain an airway. As we move towards the neck, consider, is this a patient in which you suspect a cervical spine injury? In that case, you need to provide C-spine stabilization and limit motion before you assess. If you don't suspect cervical spine injury, you can proceed. We want to palpate the neck, and we're looking for tenderness at the base of the skull, and we're just going to go right down the midline over the spinous processes of the vertebrae for that entire neck, those 7 cervical vertebrae. As we move to the chest, you may need to consider modesty, especially for our female patients. If you ask them to breathe deeply and they're able to do so without any discomfort, that gives us a clue that the ribs are likely intact. We can go ahead and place our hands on the side of the patient's chest, understanding that those ribs connected to the sternum, connected to the vertebrae, form a solid circle. So if we squeeze from the sides while they inhale deeply, we can again assess for any pain. And if we need to further assess, we can put the back side of our hand on the patient's sternum, and this is very dignified, and we can put the other hand on their spine and once again ask them to breathe deeply. This kind of looks at it from another axis, not from the sides, but from posterior to anterior. As we look at the abdomen, exposing the abdomen on the hill may not be done, but we may need to, given a pertinent medical condition that we're responding to. We want to note if it appears flat, normal, or if there's some distension there. We might look for discoloration or some bruising there in the case of a traumatic injury. And then we're going to systematically palpate each of the 4 quadrants using the umbilicus as our landmark, and we want to palpate the painful quadrant last. Palpate firmly. You notice that the patroller in this picture has fingers on the abdomen with the second hand over the top, and that allows us to just press firmly and consistently on all 4 quadrants. When we examine the back, especially if the patient is in a lying position, it's going to be part of our log roll when we move the patient onto their side. And just as we did with the neck, we want to palpate down the midline, looking for those spinous processes and noticing any of those things we saw with DCAP BTLS, in particular tenderness, some sort of deformity or a step off along the spine, and we're going to use the tips of our fingers all the way down to note that. When we examine the pelvis, we want to put one hand on each side, just as we put hands on the sides of the rib cage previously, and we want to firmly but gently squeeze the bones towards the middle medially. We only want to perform that test once if we have an unstable pelvis and we manipulate excessively. Any sort of clots that may have already been forming and are actually in our favor, we may dislodge and re-trigger that potentially life-threatening bleeding. Note any instability or movement. If you suspect an injury to the anterior pelvis, for modesty, you can place the patient's hand over the pubis bone, the symphysis pubis, and then press on the patient's hand looking for a painful response. When we examine the extremities, we want to just note if they appear normal. That anatomic alignment or position is one bent, is a deformity present in such a way that it's that obvious. We're checking for bleeding, and we want to do each side separately. If we palpate at the same time and we get a painful response, the patient says, ouch, wait a minute, I have 2 hands on the patient, which side was it, left or right? So one at a time. Ask the patient to point to where it hurts and palpate the non-injured part of that extremity first, working closer towards that painful part so we can isolate it and then focus. To assess the entire arm, just begin at the shoulder, move distally, palpate the shoulder blade and the clavicle at the top, then just wrap your hands around the upper arm with pressure, palpate the entire arm down to the hand, repeat it for the other side. As a final step, check for equal pulses in both sides and check for equal grip strength in both sides by asking the patient to squeeze your middle and index fingers simultaneously. We hope that they have equal strong grip size. For the legs, again, do they appear normal? Is there a deformity? Is one shorter than the other and perhaps presenting with rotation, indicating an injury? We'll feel for deformities, palpating the entire length, very similar to how we did the arms. And then if we can, we want to take a look at the patient's foot, oftentimes not possible inside a ski or snowboard boot, but then repeat on the other side. Our neural and motor function on this side is going to be to place a hand against the bottom of each of the patient's feet and ask them to push down like on a gas pedal. We can also ask them to dorsiflex, and that's like pull up with each foot, and we can evaluate sensation as well. In summary, that head-to-toe assessment should be systematic. We're looking for those things that are signs, those objective findings that we can look, listen, or feel using that mnemonic device, DCAP BTLS. Always wear gloves and personal protective equipment as part of our universal precautions. It also makes it a little more clinical.